I've got 2 questions already coming from outside, so you're also invited to here come to the microphone if you've got questions. But there is apparently people that are also following virtually, and I do see the names of the people that asked the question as well. Julian Schulze-Zwisch, a good colleague and friend of mine from Hamburg. So he asked, great talk by Madeleine. Do you see a similar correlation with IL-18? That's what he's asking. Do you remember your correlation you had with some of the cytokines? He's going into a very specific question.
Thank you for the keen interest. Okay, so this is not going to look really good on my part. We did have a panel of cytokines, but I cannot remember IL-18. But my email is easy to find, and I'll be more than happy to actually share the whole panel and entire correlations with him.
And I think the paper is out already now.
The paper's out already.
A preprint. He can refer to that one.
But I don't think the entire panel is in the paper, so definitely do email me, and I'll be more than happy to share all the results.
Second question. Okay, there is another one here.
I can answer that question on interleukin 18 because I'm
there
an
you
author
go.
on that paper.
If there is knowledge,
and it did decrease.
It did decrease. Okay.
Yes.
Okay. It did decrease. Yeah. Okay. So there is another question that came up here, and I guess I know the answer because at the very end of your presentation, there was something to suggest the answer. Can we recommend patients to add fostemsavir if they have inflammatory symptoms related to HIV?
If they have what symptoms?
If they have inflammatory symptoms related to HIV.
Well, I think that definitely not at this stage. I think that we need a demonstration through the trial. So fostemsavir at present is only recommended for virological control if you have uncontrolled HIV due to resistance. So the proportion of people that are actually taking fostemsavir is very little. So I think it's premature to recommend fostemsavir for inflammation-associated symptoms if you're living with HIV. One of the first elements of answers for this is that there are many possible causes for inflammation if you're living with HIV or not. So I think we really need results from a controlled trial to know whether the GP120 associated inflammation is curbed to a significant degree amidst all the other inflammatory causes that exist in the human body. The other thing is that as we've seen in the study, not everybody living with HIV has detectable GP120. That's why I sort of want to pitch it as a personalized medicine approach, because I think it's time to know more about what are the remnants of the virus that are circulating in people's body and what is their exact contribution and meaningful contribution to the general inflammation. Yeah.
As so often, if you convince with your concept, that doesn't mean that everyone should do it. So that's why you're doing the clinical trial, also with clinical endpoints. I find that very ambitious in a way, but also very brave. But I think these sort of studies will help us to really answer these questions and whether we can move this forward. Please, next question here, if you want to.
Well, I have 3 questions to each of you. One, so to Professor Behrens, if I understood you right, you said that the inflammation is higher in MSM living without HIV than in men who have sex with women. Is that correct?
So I would be cautious in what is inflammation. So what we see is that some surrogates of inflammation that we use, like T-cell activation, upregulation of markers, is different indeed in MSM as compared to MSM with HIV and people which are not MSM. What the cause of this is and why this is the case, that can be speculated. That can be STIs, other factors, but it's just the point I wanted to make is what is normal, right? So what is a normal amount and set of inflammation? That can be variable, and we need to specifically look at this if we want to tease out what comes from HIV, the virus, and what doesn't. And the animal models are perfect to look for this, and interventions that mainly look for viral protein interactions or interference address that. The other challenge otherwise I see is, and what we've been trying, to find specific interventions in one of these inflammatory pathways, and that's very complicated and very difficult because all anti-inflammatory approaches also in cardiovascular disease outside HIV, many of them have failed, although we use some unspecific ones now with colchicine and others, and try to stop that inflammatory component. Second question, if I got out.
May I continue?
Yes,
okay.
You can.
It's a question to Beatrice. You said that GP120 is expressed in people living with HIV, sometimes in the blood. But my question is it always expressed or measurable in the tissue when you make a gut biopsy, for example? And what happens if a HIV patient is cured from HIV? Do you still can you still measure GP120?
I don't think I'm the specialist in in this type of question. What I showed on the slide is that even people with a control viral load under our treatment, they still, in 1/3, can measure a GP120, and sometimes at high level in some tissue that are very important for the immune response in secondary lymphoid tissue, like the spleen and the lymph node. For answering your answer about the people that are cured from HIV and that are very rare, first of all, I don't know.
Yeah, I think there's two things that we probably need to distinguish. So what is cured? So a patient that, like the second Berlin patient that was presented yesterday, that would be a condition where we have to assume that HIV is really completely gone. There is no viral replication. There is antibodies that disappear. So I would assume there is no GP120 detectable. But I think that question is very important, to be honest. We applied just to address this scientifically, because what if we achieve remission, like, elite controllers, HIV controlled by the immune system, which then doesn't require treatment probably, antiviral treatment. Is there an inflammatory background that we achieve, which then the question is as good or worse or better as what we have with AIT? So I think it's an important question, but it's difficult to address. We would need more people being cured or being able to control the virus to study this properly. Okay, we've got one more question here also from external question, which is related to the measurement of GP120, but we'll take your question as well.
Thank you. A question from Madeleine. So what proportion of patients who have soluble GP120 detectable have coronary artery disease and vice versa?
Okay, this is a very good question. I'll have to refer, this is all in the paper that was published. So first I need to speak about the subclinical coronary artery disease and the other. So basically the people that go into the CT scans are people that do not have overt cardiovascular disease. So they've never had heart attacks and they are not aware of having any coronary artery disease. And in the entire sample, there's about 60% that have detectable coronary artery plaque under cardiac CT. But when we look, then that proportion is actually the same whether GP120 is detectable or no. So there was no statistical difference in the presence or absence of coronary artery disease when you look at GP120. The relationship we could find was really with the size of the plaque for those that had plaque and detectable GP120. I don't know if I'm answering the question correctly.
We've got to expect that people with HIV have more plaques and a bigger size to start with as compared to people without HIV. So my understanding...
I guess the issue is, to what extent is GP120 the primary driver?
Absolutely. I absolutely agree with you. And those are cross-sectional data. So there's only so much you can say about cross-sectional data. And as you know, by definition, certainly GP120 is not the only driving force for coronary artery disease. Traditional cardiovascular risk factors are really huge in driving cardiovascular disease in HIV and in people without HIV. So you are totally right. I don't think any causal assumption can be seen from this cross-sectional association. We do know, however, from other diseases like the classic diseases of internal medicine, psoriatic arthritis, lupus, rheumatoid arthritis, that the systemic low-grade ongoing inflammation, even under treatment, is linked to cardiovascular disease. So this is the component of the cardiovascular disease that I believe might be driven by GP120. But I totally agree with you that it is not the only driving force. And whether the additional risk that's inflammation-driven, that might be GP120 mediated, is clinically significant or reversible, this is totally up in the air. This is why, to re-echo the first question, this is not something we can consult patients to take now, by no means. And this is why hopefully the RESTART trial might shed some light on it.
Okay, so we'll see how complicated it is and how complex. It will be funny to see that an antiviral drug licensed that way probably can prevent, surrogates for cardiovascular disease. At the same time, it reminds me a bit the design and also the endpoint, like studies Stephen Greenspoon did with atorvastatin, treating people living with HIV, and to show that an anti-inflammatory effect can lower the size of those plaques and the swelling of the artery wall, and that paved the way to then go into the REPRIEVE study. One last question, because we need to leave the room, unfortunately, in a few seconds. Please.
Yeah, Ralf Wagner, University Regensburg. Beautiful talks, by the way, at this early hour. Thank you for this and for the good discussion. I'm wondering, you probably have discussed, Madeleine, with your colleagues. What is the reason? Is there any model why GP120 is expressed in some of the individuals? And is GP120, is that the only guy that is expressed, or is there still other proteins? Mm-hmm. Like, for example, the envelope is made from a bicistronic mRNA. VPU, for example, would be also a candidate. Did you also look into other proteins?
So thank you, because this is an extremely interesting question, and I had the same question to put to Andres Finzi when he proposed to measure this in my cohort. And naively, because I am a clinician, not a basic scientist, I asked him, well, measure everything and we'll see. And he said, you clinicians, you don't realize these things are complicated. And so the short answer is that he only measured GP120, and we have a collaboration now with Alberto Boschi to measure also P24. But I would like there to be possibility to measure more. And where is this GP120 coming from? These are people that are virally suppressed using a clinical threshold. So our threshold was either less than 50 or less than 20 during the time of the study. So is it that there is residual, very low-level HIV viremia, or is this coming from the reservoir? We did look at reservoir measures in plasma, so integrated HIV DNA and total HIV DNA, and there were no satisfying associations there. This is only the circulating reservoir, which, as we know, is not a good measure. So unfortunately, I cannot answer your question satisfactorily. Because mine was not answered satisfactorily either. This is in process, so hopefully we'll gain more knowledge in the future about the persistence of other constituents of the virus. The hypothesis that GP120 is causal is largely based on the in vitro data, as well as the biological plausibility that one molecule that HIV presents to your immune system will be antigenic and will be strongly pro-inflammatory, and the in vitro data that shows that soluble GP120 triggers a cytokine burst from monocytes, as well as ADCC. So I guess the hope that, and as well as you know, there are no other constituents of HIV for which we have a readily available, non-toxic, FDA Health Canada and Europe approved oral antiretroviral. So there's good biological plausibility, there's good in vitro data, there's good cross-sectional data now, and we have the drug. This is why I think it's time now to test this hypothesis. But I fully agree with you that viral persistence might not only be about GP120. And it might be time to revisit at large the paradigm that undetectable HIV viral load is the finish line in terms of controlling this virus.
Okay.
Yeah, thank you for the question.
Thank you.
Probably just to add this on this, but there is no commercial available measurement or system to measure GP120, so that is a tricky thing, but I can also add that seen from other groups, Hendrik Streeck in Bonn, who established also other measures to address this and measure GP120, and it finds it in several similar percentages in patients, which reassuringly to me means, okay, that could be an independent path, and more arguments, of course, come from the fostemsavir trials that have shown that if you block viral replication with temsavir, that there is good immune reconstitution. That paved the way for the hypothesis, is there also inflammatory suppression? But of course, it could be many other products from the virus, aberrant replication or whatever.